president at that time, as he is now, of ALFAPSY, proposed that we collaborate, and that we couldn't find a better way to do that than to encourage him to join us as an affiliated association of the World Psychiatric Association, which has happened formally since then. That also gave us the pleasure of to know Antoine Bess, who has inspired us since we met for the first time, and continues and will continue to inspire our steps in life. And more recently, we heard about Apricot in New York City, and this that its emphasis on the word, which is so clear in this encounter, I think is quite inspiring to pay homage to a fundamental element, not only for profession, but of our humanity. It is said that communication is not a means, but an end. And in that sense, whenever we communicate appropriately at the various levels where we have the opportunity to communicate with patients, with families, with other health professionals, that communication already involves the centrality of what we can achieve in our profession and what can advance ourselves as human beings. So as you can see, I am at ample basis to be very happy to be with you, and I'm delighted to have also the opportunity to participate in the program, including in a humble way about diagnosis, which you are going to address very soon this morning, because that is a key stone of healthcare in general, but needs to be formulated in the proper way. So thank you very much for the opportunity you have given me, and welcome again to Mount Sinai for this encounter.
Des médicaments, mais ils ne sont pas considérés comme des effets des médicaments, mais s'ils provoquent une certaine symptomatologie, donc qu'il y a une catégorie supplémentaire pour la pathologie en tant que telle. Donc, c'était catch-22, c'est la même question.
C'est redondant.
Yeah. So now we are going to listen from the floor. And so, what are the questions? You have to be in line there to raise the questions, on one side or the other. I don't know who was first, if Brooke or Patrick. Patrick.
Yes, thank you very much to all the panelists. It was very interesting. The discussion was very interesting. I have two questions. The first question is for Professor Summers and Liza Cosgrove. I think that I would like to pose a caveat about the negative aspect of psychiatric diagnosis. I think that sometimes the psychiatric diagnosis could have a positive aspect. First, I received somebody who has had I would say, who was undergoing an acute melancholic episode. It was a very emergency, and it was not a depressive major episode, it was a melancholic acute, and it was emergency. The suicide risk was very high, and I have to pose a diagnosis, and I think it's sometimes the diagnosis can save life. That's the first remark. The second remark is sometimes naming the suffering with a diagnosis, even if it's not a good naming, but the operation, the symbolic operation of naming, could have an outcome, could have I would say a result that could reduce the suffering, could relief, could have consequences of relief, only by the operation of naming. It's not sufficient, but it's a positive aspect. The second question is for Jalil. Jalil said, it was very interesting, he said about the legacy, the European tradition, psychiatric tradition. But we don't. I think it's not good to have a Manichaean point of view. good psychiatry of the past and the bad psychiatry of nowadays. I think the psychiatry was. I think I read a study. The average practitioner, clinical psychiatrist or clinical psychologist, usually makes the diagnostic in the first moments of the encounter with the patient, the 15 first minutes of the encounter, and it's because he reacts. He is sensitive to prototypes, and when I would say when the picture, the clinical picture is far from the prototype, the diagnosis is uncertain. And that's why the past, and we don't have nostalgia of the past, because the psychiatry was not very interesting, even with a dose of psychological, I would say, practice. I think it's not necessary to be Manichaean in the past and nowadays. And that's why it's a caveat of your remark about the tradition and the legacy.
Do you need a translation? In which case, we'll ask Patrick to restate in French. Do you? No?
Bon, je peux dire en deux mots. J'ai dit qu'il y avait un diagnostic positif, il y avait un aspect positif au diagnostic, il y avait un aspect positif au diagnostic. J'ai donné deux exemples. J'ai dit que dans le premier cas, j'avais reçu quelqu'un qui avait un épisode mélancolique aigu, et ce n'était pas un épisode dépressif majeur. Et je pense qu'en faisant le diagnostic, de par mon expérience clinique d'épisode mélancolique aigu, j'ai contribué à sauver une vie, parce que c'était une urgence psychiatrique. Et que ça, c'est l'aspect positif du diagnostic. Le deuxième remarque que j'ai faite, c'est que il arrive que simplement le fait de nommer, c'est une opération symbolique, de nommer la souffrance, donner un nom à la souffrance, peut avoir un aspect d'atténuer la souffrance en tant que telle. C'est pas suffisant naturellement, mais c'est un aspect. Et la question que j'ai posée à Djali, je lui ai dit, il ne faut pas être manichéen dans la mesure où, dans le passé, il a parlé de l'héritage de la clinique européenne, et c'était pas si intéressant que ça. J'ai vu une étude où les diagnostics psychiatriques par les praticiens étaient faits dans les 15 premières minutes de l'entretien, et généralement ils ne changeaient pas d'avis. Pourquoi? Parce qu'ils réagissaient à des prototypes. Et plus, ce qui est quand même un problème, et plus le prototype de schizophrénie, prototype de mélancolie, prototype de ceci. Et quand le tableau clinique s'éloignait un tout petit peu du prototype, le diagnostic devenait n'importe quoi, devenait absolument incertain. Donc je voulais dire que j'étais d'accord que pour la tradition européenne, il fallait nuancer et qu'on ne pouvait pas avoir la nostalgie.
We are going to reply, but I recommend the speakers to be concise, because we have many questions, so we'd like to have the chance to let everybody raise his own question and have an answer. So, Jalil, you want to? No, Lisa.
Just very briefly, I couldn't agree more. I would say that we should never presume to know in advance the meaning of a diagnosis for a client. For some people, as you were saying, it could be enormously helpful. And part of the therapeutic process and engendering rapport is around, I think, a discussion of the meaning. And the second point, in terms of the dichotomy, again, I could not agree with you more. I like Pat Bracken, the Irish psychiatrist, who suggested that instead of this anti-psychiatry, pro-psychiatry, we move toward a post-psychiatry that undermines this dichotomous thinking and engenders dialogue.
Yeah, I would say pretty much the same thing. I don't really disagree with anything that you're saying. I think the point is that we want to understand people, we want to do what's best for them. The purpose, I think, of my remarks, and I think of Lisa's remarks, are to counteract a tendency to misuse diagnosis. Not to say that there shouldn't necessarily be diagnosis when it's appropriately applied. I mean, there is such a thing as depression. People do get depressed. People do get anxious. And, you know, I see people and I see them as anxious or as depressed or whatever. And certainly in emergency situations, we see them in certain delimited situations, and certainly there are medications that can be used in certain specific situations. But I'll take the kind of example that I'm talking about is, we go back to what I said before about the treatment of psychosis and schizophrenia and the difference between the United States and other countries. And what the World Health Organization found out, now I haven't done this for a while, I used to run a program for very disturbed, psychotic, severely disturbed patients. And I used to talk to a number of European psychiatrists, and what they would do is they would treat people with psychotropics in the acute phases and basically phase people off and use other forms of care, nursing care, environmental care, exercise, other things. Whereas Americans would just simply put much larger doses of medication into the patient and keep them there for a long period of time. It's that kind of difference. And Americans, of course, had the poorer outcome. And that's the kind of thing I think that we're talking about. And so it's the kind of use of diagnosis and the kind of use of medication, I think, that becomes important. So basically, I'm agreeing with you, and I think it's this kind of a reification of diagnosis and the reification of medication as a biologism and a scientism that is at issue here.
Yes, and I think online with this, that of course diagnosis is very important, but it's also very important to see what kind of diagnosis we are using, because, for instance, we see, there are many diagnoses that are just only based on the symptomatology and not on the structural problem of the patient. And I think that this differentiation between symptoms and structure is something that it's very important. In other words, when we say we see many depressed patients, the point is that now we have the category of depression, right, that has been introduced in DSM. Now, according to a different approach to diagnosis, depression is not a pathology. Depression is a symptom, right? And as such, it can emerge in different kind of structural pathology, right? So we see how the confusion of diagnosis, leads to all sorts of implications, including the usage of certain medication that are inappropriate for that particular case. I think that Marco can say something about that.
Say something about it, because I would like to say something about that. I think it's very important to underline what Paula is saying, because the difference between phenomena and the structure enables us to make a much more precise diagnostic. When you think that to Freud, diagnostic was something made in the preliminary interviews just to discriminate neurosis and psychosis. And he had many motives to do that. But we must understand that to psychoanalysis, diagnostic is made under transfer. So we may diagnose structure after a long time of treatment. So it's very different from diagnosing about the symptoms. The symptoms may be present, for instance, the difference between psychosis, schizophrenia, and folie hystérique.
Hysterical madness.
Hysterical madness, that is very, it's not so rare. It's very important to do, because if we treat hysterical madness with neuroleptics, we are going to mask tableau, a frame, a picture, a clinic picture, and we are going to submit the patient to neuroleptics without no need to do that, and we are going not to be able to introduce the treatment on transfer. So that's really important.
Oui.
Patrick, merci de me donner l'occasion de préciser ma pensée et de dire
Thank you, Patrick, for giving me the opportunity to express my thought and to
et
say
de dire que je ne suis pas nostalgique.
that I am not a nostalgic.
La nostalgie, c'est dangereux.
Nostalgia is dangerous
Parce que si la nostalgie touche trop à l'imaginaire,
because if it touches too much on the imaginary,
on embellit les choses
one embellishes
jusqu'à la caricature.
all the way to caricature.
On en sait quelque chose aujourd'hui dans le retour aux traditions.
And we do know that today through the sort of return to tradition.
Et donc, pour moi, citer justement aussi bien la tradition séculaire qui remonte au fond des âges, hein,
For me, to cite, for example, secular
Que
tradition, which
citer-
goes back all the way
que
back,
citer la tradition psychiatrique européenne, aussi bien ça que ça, aussi bien le retour à cette grande tradition que celle de la psychiatrie européenne,
the return to this tradition, as well tradition of classical psychiatry.
parce que pour moi, c'est un travail de mémoire.
Because for me, it's work that's about memory,
Et la mémoire est essentielle pour la transmission.
and memory is essential to transmission.
Alors, ce que je déplore, encore une fois, c'est que moi, le DSM ne me poserait pas de problème si on connaît tout ce qui l'a précédé.
What I lament is
Le DSM ne poserait pas de problème si on connaissait et si les jeunes générations savent ce qui précède.
DSM would not be a problem, would not cause a problem if we knew what preceded it.
C'est-à-dire que c'est en connaissant son héritage
It is through knowing its inheritance,
qu'on peut s'approprier le
one's
présent.
inheritance, that one can appropriate for oneself
Voilà.
the present.
Voilà. Et donc, l'histoire des classifications, c'est une histoire des époques. À chaque époque,
So the history of classifications is a thing about time. At each period of time, there were classifications.
à chaque époque, son raisonnement et ses classifications et sa pensée.
To
Voilà.
each period of time, its classifications, its forms of
Et je ne veux-
reasoning, its thought.
Je ne veux rien renier, même pas le colonialisme qui a eu lieu dans mon pays,
And I do not want to
renier, deny,
deny
oui.
anything,
Oui.
even colonialism, which took place in
C'est-à-dire-
my country.
Ça fait partie d'un héritage que je me réapproprie.
That is, it is all part of an inheritance which I make mine.
Et j'en fais autre chose.
And I make something else with it.
So I think that we can, Brooke, you're next.
Yeah, I'm going to stay right on topic, and I'll be as brief as possible. I'm really directing this question to those in the American